lovelies, and welcome to today's video. My name's Alya and I'm so glad you stopped by. Today we're going to be talking about angle closure glaucoma, which is such a scary topic and unfortunately has been coming up more and more in practice. I've just been seeing so much of it lately, so I couldn't help but wanting to share this with you guys. So I hope you stick around and learn about this really scary but incredibly preventable disease that can cause instant blindness in some cases. Stick around. Okay, so angle closure glaucoma is different to open angle glaucoma, or what's known as primary open angle glaucoma, POAG. It's still the same disease, or all glaucomas are still categorized in the same way, in that any glaucoma will cause damage to the nerve at the back of the eye. Now, the way it happens is that pressure builds up at the front. No matter what kind of glaucoma it is, it's all about the pressure in the front building up, putting pressure all around the whole eyeball, and unfortunately stopping the flow along all those little beautiful delicate nerves throughout the eye. And then of course when they come together to form the optic nerve, that optic nerve has sustained damage because all those little feeder threads have been squashed, have been stomped on. The way I sort of think about it is, if you can imagine a beautiful vine, and then you've got the roots at the bottom, or the stem at the bottom. If you're going to kill off all those beautiful tails, what's going to be left of that stem? It's going to be looking pretty poor and pretty skinny if all those beautiful threads along the whole garden have been squashed. And that's kind of how the eye works. The pressure itself is a very mechanical process though. In primary open angle glaucoma, which I've spoken about before, it's all about the pressure building up, and then we go in and we try and bring that pressure down. So it's almost like the tap has been left on too high and not enough drainage is happening. Now, closure glaucoma is entirely different in its mechanics. With open angle glaucoma, we're talking about too much production, or not enough sort of status quo, not enough going out for the coming in. Whereas in closed angle glaucoma, it's an entirely different beast. Here we're talking about an otherwise normal eye, so there's no chronic disease to speak of usually. There of course are individual cases where there is, but a classic closed angle glaucoma, there is no actual glaucoma to speak of. What's actually happening is that drain is closing up, and these things happen so gradually. A lot of the time, especially lately, we've been seeing a lot of fairly normal eyes that are just really super shallow. Or I've had a few cases where, again, fairly normal eyes, not really even that shallow, but the actual area that needs to be draining is shallow. So it looks okay to begin with, but at a closer look and with more testing, we actually find not so great. So what we're talking about is a drain, a natural, beautiful drain that sits all the way around the perimeter of the iris. So between the cornea and the iris, there is a drain. And that drain can be quite deep, depending on how deep your iris is sitting away from your cornea, or it can be quite shallow. And it could be because the iris is shaped in such a way or such a way. It could be that the cornea is quite steep. There's different parts of the anatomy that can cause that drain, or the angle, that little corner there that they create, to be somewhat misshaped. Now, my experience was always classically, it happens over time. It's usually a long-sided eye, so it's a smaller eye. There's not much room to move to begin with, and as we age, we all get shallow. And then, of course, just one thing catches up with the other, and we do risk closure, in which case we just go in and fix it. But as I mentioned more recently, that hasn't been the case. We've got all these like borderline people coming through with anatomy. Is it, isn't it? Is there damage? Is there damage? So what we've had to do more recently is treat every single narrow angle as a classic glaucoma. Are they sustaining damage? Are they closing intermittently? Are they really borderline, or are they more serious? All these new questions have arisen because of these really strange and very unfortunately becoming more common appearances in the clinic. Now, the anatomy, I'll find some images for you guys to explain. It's all about this wonderful meshwork. So if you can imagine like a sponge, wonderful meshwork called the trabecular meshwork. What it does is it's just a literal sponge. It's a a system of tubes that absorb the pressure quite naturally out of the eye. It just flows out along the perimeter and then gets absorbed into the rest of the drainage system of the face. Now, that's assuming that the same amount that goes in, or the rate at which fluid is created or is gathered up in the eye, is the rate at which it goes out. So back to that analogy about a drain, if you're putting the tap on really high but you drain and your drain's normal and you just put on the tap really high so the normal drain is just not coping, that's what you're calling open angle glaucoma. But in these cases you've got this tiny little hole and the tap is actually not on high at all, it's just that the hole is closing over. We have seen, in an open angle example, we have seen people that have just developed closure from debris or from other things occurring, so a secondary cause of glaucoma. That's not what we're talking about. We're talking about the actual drain becoming super small. So what do you do if you have a patient with a super small drain? Now, you would think that you can just widen the drain. That's what you would do in a sink, right? You would find that the drain is too small, it's shallowed over time, and you would try and stretch it open. Unfortunately, you can't do that with the eye unless you want to cause extreme damage. So what we've created over the years is what's called an iridotomy. Used to be an iridectomy, used to be that you would create a cut in the iris, and lucky we're in 2022, nearly 2023, and we don't have to cut anything. What we actually do is use a really funky laser that just pierces a hole. Simple as that. Not painful like an ear piercing or anything else. Just a really tiny little laser burn. It's probably about 1 millimeter, probably less in size, and it has to be patent. It has to be all the way through the iris. Iris is just muscle, so it's no different to an ear piercing in terms of damage to the anatomy, but it's perfectly painless because there's no pain receptors in the area that's being pierced, and that creates an alternate drain. So in my mind, the way that drain analogy works is, you know that you got that overflow hole in some drains? I'm sure I'll find a picture somewhere to show you. So basically when that drain gets too high, it will just use the overflow. Of course, the eye is not exactly like a drain. It's an enclosed area, so it's never going to just flow out, but it's a similar analogy in terms of the mechanics. The beautiful thing about that hole is most times it has absolutely no side effect, so it's perfectly safe to have it done. So I often get asked the question, well, if you don't know if I am or I'm not borderline, why wouldn't you do it anyway? Well, look, the reason is that you never want to do any medical procedure, no matter how small or how inconsequential or how benign, unless you absolutely have to, because there will be that one case out of 2 million or whatever that you'll be the unlucky one, and something will happen to you. So we don't want that. So if we do see that somebody does need the procedure, we absolutely do it. We do it in the chair, so you don't need a special procedure or anything like that. It's just done in clinic. It takes about 5-10 minutes. The only real kind of nasty thing about it is the drops that we use to ready the iris for piercing can cause a little bit of this muscle ache or headache. So often we have some paracetamol on hand just to help people battle through that headache. And it usually goes away when the procedure is performed because that muscle is then relieved and the headache goes away. So it's not without its consequence, but it is very safe. So there's definitely easy enough solutions, but how do you know if you're at risk? How can you possibly know to present yourself to a doctor? How do you know if your iris is narrow? And unfortunately, the only real way to know is to have a professional check you. But there is one little trick that you can do at home. You just take your phone and you shine a light inside your eye, just from the side there. The idea is that you should imagine like a cat's eye. You should see a definite shadow between your iris and your cornea. So that it's kind of easier, I would say, with a lighter eye, like a hazel eye. It's definitely a lot harder to see in a darker eye, but not impossible. So just to demonstrate, I'm just going to switch this torch on, just a normal phone. I'm just going to show you how that eye illuminates. See how the very center of my eye is nice and light, and then I've got this dark rim going around the perimeter, and that's just demonstrating exactly what a deep iris or deep iris position or a deep anterior chamber should look like. And mine's not even as deep as it could be. There are definitely some out there twice as deep as mine in terms of millimeters measurement. So it could definitely be deeper, and mine's quite easy to demonstrate. I hope it does translate well on camera, but there will be diagrams available as well. Now, you are not yourself a diagnostician, but if you can't see that shadow, just see your optician. The optician should be able to measure it really accurately, either with a slit lamp, so a little microscope, or just a torch. I just use a torch clinically, and then I allow my machines to take millimeter measurements for me, but the torch is always the first go-to to know whether I do need to do further testing. Now, why would that be dangerous? Why is angle closure more dangerous than such a panic that we have to go and do piercings and not just give drops? The reality is that if the cornea and iris do close over, or if that angle does close over, what will actually happen is in that instant, there's nowhere for that fluid to go, and the build-up won't be just a little bit high because the trabecular meshwork will still manage most of it. It'll be fully closed over. It's going to go into crisis, which means that some people can reach pressures of 60, which is absolutely critical to the optic nerve, and it will just die. We're talking about either full blindness in a matter of days, sometimes even hours. We've seen some instances, or more realistically and more commonly, over a course of several months, we get to see pressures of more like 30 and 40, and obviously steady but gradual nerve death. So the earlier the intervention happens, the less damage will be sustained. These things are not easy to manage. It's not as simple as just the piercing, but the piercing is definitely the first and most helpful step. And then oftentimes, eventually, these patients do still need other interventions, whether it be cataract removal, because that also helps deepen the anatomy, or whether it be drops or more laser, things like that. And of course, there is always the option of glaucoma surgery, but that is the last step we take, because it does have a lot of consequence for the patient and doesn't necessarily have the best long-term outcomes for the actual overall eye health. So we definitely have that up our sleeve, but it is a last point of call. Okay, my lovelies, today was a really intense topic. I hope you enjoyed it. I hope you learned something. I just can't ignore the fact that there's just been this influx. I'm not sure if it's because people haven't been really seeing their clinicians over COVID and lockdowns and everything, or whether it's just a trend that we've been seeing in their clinic and it's just a coincidence. I don't believe in coincidences, but maybe. But I do hope that someone out there is going to go check their eyes if they do feel that they mightn't have that deep anterior chamber. Okay, my lovelies, as always, I encourage you to subscribe and check out the other videos and other fun topics about the eye and tichels and other whatnot that I talk about on this channel. So yeah, definitely subscribe to learn all the things. And if you want to see really cute photos of doggies and my boys and my fun nails that I get done and all the things that involve my crazy little world, Instagram. Sorry about that, guys. My camera just died randomly. So yeah, just telling you that Instagram was the place to go and hit follow, and I'm always as active as possible there, and sharing lots of really fun things about all the things in my life, including my wonderful charity, Super Bistro and Kitchen, and all the amazing things that we get up to there. I always like to share stories and cross over. So if that's something that you're interested in, I encourage you to go over Instagram and give me a follow there. Wherever you are around the world, my lovelies, I hope that you're having an amazing time. I hope that everything is going really well for you, and you're looking after yourselves, of course, and I can't wait to see you on the next one. Bye.